39-year-old male with colonic Crohn's disease for the last 4 years on azathioprine and mesalamine presented with progressive obstructive symptoms and constipation for the last 18 months. He had undergone endoscopic balloon dilatation elsewhere up to 12 mm for descending sigmoid junction stricture without symptom relief 9 months ago. On evaluation, intestinal ultrasound revealed short segment fibrotic stricture with pre-stenotic dilatation at the descending sigmoid junction. Endoscopy confirmed a tight stricture at this location complicated by multiple pseudopolyps obscuring the lumen. Initially, polypectomy was performed to clear the visual field, followed by endoscopic stricturotomy using insulated-tip knife with electrocautery settings of endocut I, effect 3, cut duration 1 and cut interval 3. However, luminal orientation remained challenging due to adjacent mucosal folds and pseudopolyps protruding from the proximal segment, raising concern for inadvertent thermal injury to the opposing bowel wall during dissection. Further dissection was performed by making radial followed by circumferential incisions at the 6 o'clock position. Stepwise stricturotomy was performed from superficial part of the stricture to the deeper part, making circumferential incisions. After performing considerable amount of stricturotomy, still the opposite wall was protruding to obscure the vision during stricturotomy. Hence, it was planned to resect the protruding mucosa and polyps on the opposite side. Polypectomy was done for the same, and then we proceeded with stricturotomy. During this, technical success was achieved and the stricture was crossed. Still, it was quite challenging to keep the protruding mucosa away from the other wall while doing endoscopic stricturotomy. Hence, a water pressure assisted endoscopic stricturotomy was planned. Underwater endoscopic stricturotomy was done by making circumferential and radial incisions in the stricture, keeping the opposite wall away with the water pressure. Allowed safe and effective endoscopic stricturotomy, keeping the opposite wall away, avoiding thermal injury to the opposite wall. As the stricture was longer than it was initially appreciated on intestinal ultrasound, circumferential incisions were made layer by layer, stepwise, to gradually dissect the fibrotic tissue. After considerable amount of dissection under water pressure, sufficient lumen diameter was achieved, and then stricturotomy could be performed even without water pressure. However, water pressure method was continued until all the fibrotic tissue on the inferior wall were excised. Even after doing considerable amount of stricturotomy in the inferior wall, still adequate luminal diameter was not achieved due to protruding mucosa from the opposite wall. Hence, endoscopic band ligation was performed for the proximal protruding mucosa. However, still the lumen was obstructed. Procedure took almost 2 hours, and it was decided to do second session on next day. On next day, many other pseudopolyps were seen to obscure the lumen, which were removed using polypectomy. This is one of the polyps with a thick stalk. There's mild bleeding which stopped spontaneously. All these obstructing polyps were resected to facilitate further stricturotomy for the stricture. Still, after doing adequate polypectomy, the mucosa was protruding from the other side of the stricture, that is the proximal side. Hence, it was decided to cut that part of mucosa below the band that was applied the day before. This led to considerable luminal diameter. However, still some mucosa was protruding. That time we did a retroverted view of the stricture. From there, resecting the fibrotic tissue was difficult. Already there was a little deeper injury in the mucosa, so we did a submucosal injection. This was followed by mucosectomy and removal of the polypoid tissue and resection of the opposite mucosal protrusion was done until adequate luminal diameter was achieved. This was followed by further stricturotomy to relieve the stricture and cut all the fibrotic tissue. Endoscopic stricturotomy and achieving adequate luminal diameter, the mucosal defects were closed using hemoclips.